last year I was very pleased to be part of the AgPower Train the Trainer team with the Healthcare Homes team, and I worked with Dr. Kirsten Meisinger, and I know she'll say to me, drop the doctor, and I said, well, drop the sister. We're colleagues here and we're working on the same, collaborating together to look after our patients, because that's what we're all here for, patient-centered care. So without further ado, here's Kirsten.
Hi, and hi people I know. And so it's actually, I hugged my way through the room. Hi, I know, hi pal. Wait, I think, Jane, wait a minute. Come please. You already managed to talk without giving superpower information, and I'm about to do it. You didn't, you sneaky, right? You snuck back. I'll do mine first so you get a chance to think, all right? No, hey, but stand next to me for support. All right. I am. I'm a doctor. You guys know that. Come on. I'm a nice doctor, but I'm a doctor. All right, so let's see. My superpower that I want, that I don't have, would totally be flight, because one of the things when you're doing system transformation is it really helps to be at the crop circle level. Like I was flying here, which from Boston takes quite a while. I was flying over the US, and there's all these circles all over the place, and then there's these funny circles and then these things on top of circles, which it turns out are mountains. But I was up really high, and I was like, wow, this looks totally different than if I were on the ground. And so I would love that as a superpower, because as you're changing systems, that's the view. You need to be able to kind of go back and forth. Like, you need to be able to get into a plane every once in a while and just look and see. But my organization is really cool. It's called Cambridge Health Alliance, and we are a unicorn in the forest in the United States because we are a public institution in a country where there's essentially almost no public care. I know, I feel like in Australia, everyone in the United States is a unicorn to you guys, because you guys make sense and we don't. But in the land of make-believe in the United States, we're still special, because we're also really heavily primary care and psychiatry. So actually the superpower of CHA, which is what I'll call it because Cambridge Health Alliance is too long, is invisibility. Because if you think about it, guys, right? When I do my best work, and I'm rotten at being invisible, I'm wearing bright red shoes, it's just not ever gonna happen. But CHA is fabulous at being invisible, because when we do our best work in primary care and psychiatry, nothing happens. Nobody gets cancer. Nobody is sad. Everybody lives to 90 and is happy and fulfilled. That is success. There's never gonna be a TV show about primary care, right? Because it's just not sexy in that I'm going to stick a needle in someone's chest kind of way, but it's so fundamental to making the world a better place. So, and CHA really does do that, which is why I feel like I'm stuck for life and happily stuck, but it's a wonderful place to work, so you're all welcome to come visit anytime. And now I'm totally not letting you off the hook. Team-based care, baby. Back me up, you gotta do it too.
Oh, well, I just think, one person can do so much, but as a team, the team contributing together is just, multiplies the effect, and so looking after the patient. But I really liked the girl over there, talking about getting into the other person's head and knowing where they're coming from. So that's what superpower I'd like.
Beautiful.
Okay, take it away.
How do I move slides and things like that? Up here? Oh. Can I not stand here, or do I have to stand here? Oh no, good, here's a thingy. Okay, so I hope this is okay with you, because we're kind of already here. But really what I wanted to do, because knowing that nurses all have superpowers, is I didn't want to do another talk of like, wah, 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 like general concept, and then you guys go home and you're like, okay, yes, that's nice, but how, right? Like, I wanted to leave everyone today with a really concrete vision of how this actually looks. So this is actually a presentation that I did with Went West in Sydney now years ago, so you'll see the dates are all wacky. Because actually I didn't do the presentation, Amberly did, who's one of the nurses on our teams. And she's fabulous, and you should totally bring nurses, not me, here. I was cut rate, so that's why I'm here. I was here for another reason anyway. But I was a little obsessed with coming to this conference. I think I like overtly harassed Tina and Jane into like making me do this because I love you guys, and I can't do anything now without nurses on the team. So let's go through the case. But I'm also going to ask you guys to contribute because I am still learning about Australia. I'm learning a lot. It's really interesting. You guys are fascinating, but you're going to have to help me with certain things that might not make sense, if that's okay. So this is the true story. This actually happened. And the picture is actually my friend, not the actual patient, but he's cute, you'll see. He calls me mom, which is really weird. I'm like, how old am I really? I am actually his mother's age, and I was like, okay, now that's depressing, here we go. So this is Surya, which is actually who that is, but my patient's name is not Surya. He's a 28-year-old guy from Nepal. He presented to actually the emergency room. So Cambridge Health Alliance is a sort of constellation of care, which is a trendy thing in the United States called accountable care organizations, where you kind of have like an ER and a hospital and a bunch of clinics, and you can usually have specialty care, and you've got radiology and laboratory, and everything talks to each other. So that's cool, right? So that everything is one system. That works really well and is really important for team care, as you'll see. So he actually presented to the emergency room and had an eye abnormality where literally he was like wall-eyed. Like one eye was like, and the other eye was straight ahead. So the poor guy was seeing double. He had actually come to the US to study, could not read a word at this point, so he's like in a panic, right? He can't study, his visa's studying. So he actually was sent to ophthalmology, diagnosed with a 6th nerve palsy, and then they couldn't really figure out why. They figured, well, it might be TB, actually, which is totally wacky, right? Like, I definitely don't see this every day, and I take care of a lot of immigrants. This is kind of a cool, it's really cool if you're not poor Surya, actually, is what I mean to say. But I was like, whoa, what is going on? So while he was hospitalized, he got really high sugars, kind of out of nowhere. Poor kid, right? I mean, he was cute, right? Like, totally healthy, his whole life ahead of him. So yeah, this is from 2013. So we really have been doing this a while. We've been actually doing this since 2005. But, and I think like someone said, this is sustainable because I can just essentially use this case again. We've gotten a little better, but only around the edges. This is really, the core is still there. So they recognized immediately that this guy has no GP, and neurologists aren't going to manage diabetes, right? There's no way. So they just referred him to us. We have a lot of Nepali patients at Union Square. So what happens in the United States at the first GP visit is sort of this, right? So now read those things, guys, and figure out, or you can see some of the things, it's already team care. So when a patient arrives the first time at my site, Union Square is part of Cambridge Health Alliance, doctors do things, nurses do things, medical assistants do things. Oh, shoot, what do you guys call medical assistants again? MPA. You have to put an extra letter in for you guys, right? So medical practice assistants do things. We have a ton of those guys running around for regulatory reasons in the US. And then I'll get to, yeah, no worry, I'm getting to nurse practitioners. I have a picture of Rosanna. So, so some of these things, all of these things got done. It would be really hard for me to get all of those things done, actually, right? That's asking a lot. So I have 20 minutes for a new patient visit. His eyes going, right? He's got all of these things I have to look at from the chart that are old. But look at the amount of stuff that we got done in the first visit. I'm hoping I'm impressing you, but I'm impressed with me sometimes when I look at this. I'm like, really? I did all that? That's a lot. Of course, I didn't do most of it, right? A lot of it was done because we set up systems so that all of these things could happen pretty easily, right? So this is us, right? Me, and then Carla's the MPA. Two front ones, and in the back is Esme, who's a registered nurse. So if you go back, I have to do a referral. It's just what GPs under my regulatory structure have to do. Although, kind of funny to do a referral when he came to me from a specialist, but whatever, it's a paperworky thing, which we always hate. Do you guys have healthcare proxies? Do you know what that is? Healthcare proxy is assigning someone in your family the right to make medical decisions for you if you're unconscious or unable to make decisions. And poor sweetie, he's 28, but he's actually pretty sick. So, and we actually just do it for everybody over 18. But I kind of made sure it got done, because I was like, I do not know what is in your head. Your eyes doing weird stuff. You might have TB. Like, it was a little scary, the poor sweetie. And he, of course, the first visit didn't come with his family, so I wanted to know, like, who is here, right? You're an immigrant. Who do I call? I'll call Nepal if I have to. I'm fine with that, but just let me know. So, but, you know, you're faced with someone with uncontrolled diabetes who's a new patient. And reflexively, the very first thing I do is go get the nurse. Because if your diabetes is not controlled in my world, the very first thing I think of is, well, I need help. Because it's really hard to get diabetes under control, and I'm likely going to do what I can, but what do doctors do with diabetes usually? Yeah, prescribe things, right? We throw pills at the problem. How successful is that? Not really, right? You know, if you're drinking your metformin with a liter of soda, not so effective. You can't make this stuff up, right? I've seen all of this, right? You know, but I find out about the liter of soda not because I asked, right? I'm still a stupid doctor, but because the nurse on the team was like, not for nothing, but you might want to remind him not to take his pills with soda. And I was like, great idea. I'll do that, right? You know, everybody has a different role in team-based care. So it's just important to understand. And this is totally focused on nursing, right? I'll talk about other people, but I don't really care about them. I'm only doing this for you because this is a perfect case where you'll see how this goes. But basically, Amberly did everything and it's awesome. So the labs, though, are protocolized, right? These labs are standard for someone with diabetes. It's not really an opinion. It's just what we do, or it's someone's opinion, but it was long ago, and now it's just a thing, right? We check the small vessels. We want to know where we are with him with the hemoglobin A1C. So this was all done without me. I don't even have to order these. I walk in, and it's done. I can add stuff if I want. I did, actually. There was some crazy, this is a crazy case. But in general, this is done without me. Because of the warm handoff, he was actually in the clinic for about an hour and a half, and he was stressed and had to go. So we didn't manage to get the urine. But usually it's like, poof, right? Immediate perfect care. Do you guys have that term? So diabetes perfect care. It's kind of an obnoxious term. I don't like perfect. What do you guys think? Some of the things are up there, right? What would you want to know about somebody who has diabetes pretty much every year? Yeah, HbA1c. Yeah, you want to know how the kidneys are. We don't use GFRs, but we could. That's what the urine test is. It's a microalbumin. You know, if you're leaking protein, it's bad. Exactly. Yeah. We do an LDL to try and get it below 100. It doesn't always need meds, but sometimes. The hepatitis in this case was just extra because he had been on medicines for TB, which can make your liver wacky. So I wanted to make sure that no one had ordered a hepatitis panel, and he's from Asia, so I just wanted to make sure we weren't going to make his liver extra angry if it already had hepatitis. And then we actually have an eye visit every year, but you really only have to do an eye visit after 8 years of diagnosis. The problem is we routinely, all healthcare misses diabetes diagnosis pretty frequently. So it's like 10 years before most people even get diagnosed. So we just kind of start the party right away and try and get their eyes screened because it's the small vessels in the eye. So this is what it was. So here's the team I have. What team do you guys have? In your clinics? Okay, so you're missing Carla, so we have to cut Carla out of the picture, right? Are there practices that are starting to get MPAs? Yes. Yeah, all right, so actually maybe half of Carla, just cut her in half. She's a great sense of humor. She'll be fine with being cut in half in Australia.
They may not be utilising knowledge to the full extent, though.
Yeah.
So still learning.
Yep. So going back, right, number one is me. So also in team care, right? As Jane pointed out, I'm not named doctor because it just annoys me. Like, why am I a doctor and someone else isn't nurse something, right? And that in our culture, just you don't call someone nurse, right, Jamal. So they had to come up with a nickname for me because I was so obsessed with not being called doctor. So they call me Meisy, which is kind of cute. It's also impossible to say Meisinger in most of the languages I speak, which are romance languages. So Meisy works out well. So first one's Meisy. Second one actually was done by Carla. So Carla actually asks the patient who is the person that they want, right? She's been trained to do this. And usually it's just done, and I sign it because I'm not, like, you need 2 witnesses. So I was like, sure. The warm handoff happened before I even saw him because I like to talk, so I was running late. This never happens. Carla's so good. So she went and got Esme. In this case, it was actually Amberly because it's a long story. But anyway, she went and got Amberly before I even was on the scene. Amberly had finished before I even walked in the room. So Carla's basically in charge. I did manage to start the metformin. I did something at least. I feel like it wasn't totally useless. And Carla got all the labs. So actually, this is the Carla show. Now, Carla and Amberly, or Esme, right? Any RN in the clinic are like a thing, right? They run around together, they work together. Whatever Carla can do to help Esme, she does, right? Or Amberly. So they have a wonderful relationship, and a lot of these things are kind of a flow and not a stutter step. All right. So it's bad, but it's not horrible, right? What's the highest HbA1c anyone's ever seen? I love the way you guys say H. I got a 16 recently. What did you get? 11? Come to Boston, man. We can do better. 16 floored me. I was like, what are you eating? It turns out he was literally subsisting on all carbs. And I was like, well, now. Guy from India. So, but actually not horrible, right? Like, all right, so we know his glucose is high. His LDL is only 107. If you want to get to 100, that's pretty good. He might be able to do it. And he doesn't have hepatitis, so that's nice. So we still have trouble trying to get people between the hospital and ambulatory to stay on whatever track they said they wanted them to do at the hospital. I don't know if you guys are better. Is it like smooth? No. Okay. Oh, well, we'll learn together. So I had to like hit the panic button where I was like, dude, the guy's eye is still like this. Like, do something. So he was actually deemed as stable, and we have wonderful specialist GP relationships. So basically the neurologist was like, it's probably TB, but I've done what I can. You know, he's going to look to the side until the TB gets treated. Hang in there. And I was like, all right. But his sugar's still high, right? So once Amberly or Esme is on the scene, there is absolutely no chance that you're going to get away from them. So I'm now, wherever I am, right, running around seeing other patients, but he's on their list. Lord help you if you're on their list, right? You know what this means, right? So this is the care plan that Amberly developed at a visit with him 5 days later. So he came back to the clinic, and he actually had this, an hour-long visit, and this is what they developed together. So I'll give you a chance to read it, because I think it's beautiful. And this is our standard care plan that we all use, but care plans are a team sport in team care. Anyone can start one, anyone can add to one.
So is that,
Yeah.
5 days later, he's come to see the nurse and he still hasn't had bloods, is that right?
No, his bloods were already back.
His bloods are back.
Yeah, there. So usually what happens is I can actually just send an email to him with the results, because we have actually a secure patient portal, so he probably got them that way. But also, especially a new patient from a different country, often they want to come back and meet with someone for their results. So really what we do is we use the nurse visit to give the results and develop the care plan. So Amberly will say, yeah, your sugar's really high. What do you want to do about that, right? And there's 2 things here. There's the goal, the big goal, right? But then there's an action plan. So the overall goal is always interesting. Patient goals are not always what we want them to be. So we actually just called that out and said, okay, what would you like to, what's your goal for your diabetes? Right? Sometimes people's goal for diabetes is, I want to be well enough to dance at my daughter's wedding, right? I want to be able to, for him, his goal was actually, I want to have my eye fixed so I can study so I don't lose my visa. That was his goal for his diabetes. Totally legit. I don't get to comment on someone's goal other than to admire it, right? I learned this from you guys, by the way. This is not I do not sound like a doctor right now, right? I don't sound like a doctor because I got my butt handed to me over and over again until I actually figured out to shut up and listen to nurses, and that's why I'm a better human being now, which is why I'm here. So I learned that from nursing. I didn't learn that in medical school, although it's getting a little better in the US. We are making them actually do useful things like teach that in medical school now, because everybody needs to know this, right? Motivational interviewing it should be fundamental to everything we do in medicine. And if you start teaching doctors that right away, it won't take us so long getting serially dummy slapped, right? To actually get it. But I'm old, so I wasn't taught it, and it took me a while. So we then put down the medical team goals so that the person can actually see that they might be different, and that's okay, right? Who are they going to look to when they need help? Well, in this case, it's the GP, but it's also Amberly, it's the RN. And then handouts were given, and we have them in Nepali and basic English and all sorts of fun stuff. We talk about any barriers that might exist so that we just are aware of them. And then the most important part is the action plan, right? So what are you going to do? Okay, all we're going to do with him is just find out where we are. Just test your sugars daily, and then let's figure out what even the next step is going to do. Take the medicine the doctor gave you, but then we're going to need to keep working together. So this guy is pretty overwhelmed. So actually, Amberly got a call from him the next day, because even though she spent an hour with him, he still hadn't quite processed all of this. This is a lot. And this is her presentation, honestly. I wish we could FaceTime her, but I think it's like 8 o'clock at night there now. So 2 weeks later, he called in because he wasn't seeing any difference in his sugars, and Amberly actually wasn't around at the time, either vacation or she has a baby, so she might have had, Thursdays she's off, so it might have been a Thursday. And this was a covering nurse. But look how beautiful, right? Because everybody's so trained in team. Kaitlyn actually is who covered this. And Kaitlyn's brilliant, but she's also just wonderful. And so she was able to really jump in where Amberly left off and really reassure him and make sure that he felt cared for in a way that, nurses are wonderful, that you guys just do that. You're trained, but you also, I think, do it intuitively in a way that other team members don't always. So when I read this, I just see a lot of reassurance. I don't know if you guys see anything different. Feel free to comment. And now, when you're done, I'd love someone to volunteer. What would have happened if a patient called in and said his blood sugar was over 200 in your system? Current practice, not ideal practice. Oh, so help me. Really, 20. Yeah, bad. Take off a 0. So say he's calling his sugar, his glucose is 22. What happens when a patient calls the reception desk and says, my sugar is 22? Yeah, with who? Yeah. Do you have visits with RNs, or do you have visits with nurse practitioners, or both? And a nurse. Okay. What would happen in other systems? Yeah. So what would happen, though? This happens all the time to them. So they just say, you have to come in. Okay. I have to say, that's what I've seen mostly in Australia, is anyone calls and the answer is appointment. which fascinated me. And honestly, that's where we come from. I mean, people used to come in to appointments with me because they needed a piece of paper, and I would have to see them and hand them the piece of paper. And you guys are still doing that. I don't know about your doctors. I hated that. It made me insane. It did not make me happy that I could do it quickly and catch up. It made me angry that this poor person had to come in for something that was literally like, seriously, I just had to sign that. But I'm an odd duck. Do you guys know what a PHQ-9 is? Does anyone know what a PHQ-9 is? PHQ-9 is it's a screening and assessment tool for depression. So it's like a superhero depression tool, because you can use it to diagnose, but you can also then follow someone symptomatically and see how they're doing and if they're improving. So it's like one-stop shopping. I love the PHQ-9. We screen usually using the PHQ-2, but anybody with a chronic disease is actually given a PHQ-9 because it's really depressing to have a chronic disease. I don't know if you guys, right, have ever had one. It sucks. It's no fun. So a lot of people have comorbid depression. So this got done initially probably by Amberly at the nurse visit, and then the covering nurse noticed it was high and repeated it this day. Again, completely independent. Like I don't even know where I am. I don't even know this is happening. I'm irrelevant to this. This is happening without me, and thank heaven, because I'm running around doing stuff. I'm not sitting around, or I'm in Australia. No, not in 2013. So part of how we get this done is actually the huddle. So this is now Esme Marie and Rosanna. And Rosanna's training her as a human being. She happens to be a PA, but in our system, imagine she's a nurse practitioner, which I think is a more common thing for you because it's completely interchangeable other than the letters you have after your name and which degree you decided to get. And we actually have a system in Boston where they all, MDs and PAs and NPs now are starting to train together as well, which is really wonderful. So we're actually starting to change the educational process. So I'm going to just pretend Rosanna's an NP, and she'd probably be thrilled about that. But just to make it more understandable for you guys, it really doesn't matter. It's an interchangeable function, and I'll explain who she is on the team. But does anyone huddle? All right, does anyone know what a huddle is? Good. Can someone just say what a huddle is without having a stroke because it's too scary? Yeah, you could read the slide. I love it. Brilliant. How? Yeah, well, exactly, potentially. So here's an interesting thing. I have kids. Does anyone else have kids? Yeah. I don't often arrive on time when I have to drop off the kids. I try. But it's really hard when you put a huddle at the beginning of the day to get 3 females in the room on time, right? The youngins, the doctor dudes I'm hiring now as well in the clinics have the same problem, and I'm thrilled, right? Because they're like super evolved, lovely human beings. So, and we have now women and men at every different role, which is exciting. But so now the men and the women have equally hard times arriving on time, which is not a good thing. But it's a weird form of progress. So the huddle for us actually wound up feeling like a serial failure until we developed a system where we actually just go into the chart whenever you have time, make your notes on every single patient when they're coming in. So I would do this the night before on the couch while my kids are watching some stupid TV and I'm pretending to parent, right? It takes like 4 minutes. So I'm only a bad parent for like 5, if you count logging on. But I know my folks so well now because I've been, these are families I've been taking care of for 20 years. So what we do is we just go through independently, and we have a structure where we just make notes to each other. Anyone's allowed to boss anyone else around. You just have to explain why, right? So Carla routinely writes hepatitis. She's really compulsive, and she really hates it when I don't address everything on a checklist. She's like, you know that. Yeah. Madeline relates. Yeah, exactly. Madeline will tell you how it looks in her office. But I'm less compulsive. But so anyway, if she writes down hepatitis, I do it because I don't want to have her write it down again and get annoyed at me. But also, it just seems polite, right? She went through the trouble to point it out. I should probably be good and do it. So be creative with your huddles is my only message. The GP visit 4 days later, because when someone calls in and speaks to the nurse like that, we know they're a little anxious, right? So part of Kaitlyn's care plan, even though she was a covering nurse, was, do you want to come in? We offer. We're not trying to keep people out, but we don't have to have a visit for every interaction. So he did want to come in. He was pretty worked up. His eye was already starting to improve, which is really cool. So because he'd been tracking his sugars every single day, no thanks to me, but thanks to Amberly, I could actually alter his medication regimen without waiting for the next HbA1c, which is 3 months away. So that was exciting. And then he actually was like, and I have these things, they're warts. So I was like, I don't know, Amberly's done everything, Kaitlyn's done everything. Why don't I treat your warts, right? Like, what am I gonna do, right? I started a medicine and I'm like, well, it's 5 minutes. He's getting better, he's feeling good. I'm like, all right, I'll treat your warts. So I treated the warts. I try, here's my care plan. I did make this up. I think it's actually somewhat useful. It has to actually be what Amberly also says, right? But I have a lot of immigrants and we have a lot of weird food for them. So I have a really funny phrase where I'm like, because I had these wonderful times with patients where I'd be like, okay, so these are things that are actually sugar that don't feel like sugar. And I would do the first few, and they'd be like, but I can have pancakes, right? And I was like, no. Chips? No. Waffles? No. Bagels? No. Muffins? No. And by this point, they're like starting to look panicked, right? Because that's the entire American diet is carbohydrates. So I just started listing them, which is pretty funny. And then I was like, okay, then they say, well, what can I eat? And I'd be like, well, these things? It's a much shorter list, sadly, but there's stuff on there. Anyway, it was just really funny. So I now listen to my patients and I try. But I have time to do that also, by the way, because of the team, right? I actually have time to listen to people, which is why I'm addicted to team care. Okay, I just would like to reflect that this is my visit, and this is Amberly's visit. Right? This could potentially be humiliating if I were not such a fan. Look at this. Like, what? Fortunately, I'm not trying to compete. She's allowed to win. So I'll give you a sec, because she's so good. And I'll have a sip of latte. All right, now another interesting thing that happens, which is sort of buried, is actually, look under E. Patient would like to see nutrition but can only come on Monday or Wednesday, unable to make a commitment at this time to an appointment with Shalini. So referred to nutrition, but it's not looking good, right? It doesn't look like we're gonna be able to actually, how are we gonna get him there if their schedules just don't overlap at all? So things are not going the right way, in spite of all of our efforts.
Can you maybe mention how hard it is with health literacy? So I've been speaking to them. I'm just saying about health literacy and how important that is in a population where English isn't their first language. So even though we could be educating them and informing them, can you maybe mention that with this patient? Interested. Well, I'm just saying, you can give them information, but unless they're understanding it in their own language, did you have to use a translator with him? Or?
So we have 24-hour translation services, and we have all of our handouts are actually at the 3rd or 5th grade levels. So we're not doing a horrible job with it, but I also think, so he actually wanted to speak English and had a pretty high level of fluency because he was actually in graduate school here in English. So did that make a difference? Potentially, but we can't, if a patient declines an interpreter, we can't overrule that. So that is potentially partly what's going on. It's tricky. Like this is the kind of patient I think that doctors this is why they get like crusty and nasty. Like they just sort of throw their hands up like, well, what am I supposed to do about it? Is usually that kind of ego annoying reaction that we have, right? Well, the answer is, well, go get help, get your patient help. So I'm trying, right? Amberly's trying, But even Amberly's like, oh, this is not the right direction. So this is Rosanna. She's just so beautiful. I just had to take a picture of her. So Amberly went and got help. She was like, I don't know. Help, Shalini, help. Shalini is Indian and knows Nepali culture really well. So we were both like, Shalini! So we actually got him a same-day appointment on a Thursday. He happened to be available just out of nowhere. And Shalini is a team member, right? So if you go to Shalini and just look even a little upset, she will help you. And you know, everybody has no-shows. You just have to be flexible about it. So Surya wound up waiting like an hour and a half because she had to sort of wait for a no-show appointment, but he actually saw her the same day. So what happens with team very quickly is individuals don't feel overwhelmed, right? Look at all of this really constructive behavior around trying to get him where he needs to go in a really weird, interesting, difficult case. Nobody is throwing up their hands and saying, well, what am I supposed to do about it? And kind of giving up on people in a way, which is really not our role. We're not allowed to give up on anyone ever, right? That's, at least not in primary care. Dermatology, sure, they just send it back to me. I don't know what the rash is, go back to your GP. I'm like, oh. So she actually, I think, wrote a lot less than Amberly, but really spent a lot of time with him and was able to really help him with that in that cultural context that Madeline's referring to, which was missing, right? Amberly and I are well-meaning white people. You're only going to get so far. Never been to Nepal, going in September, really excited. Still not going to know what to do after one visit to Nepal, but Shalini is actually culturally competent, so that's also really important. So he saw her, and actually he was super happy. So he kind of waited 2 months, and I think immediately after seeing her, his daily sugar started to go down because we know he calls when they're high, right? We've seen that. He's called twice already. So he's been out of school, but I was sort of giving him the doctor notes. I treated his warts. Oh, right? Like, he's better. Great. I'm glad you're better. Now, 3 months go by. And he misses his appointment. What would happen in your system? How would you know to contact him? Who would identify that he missed an appointment and needs contacting? The GP would have to do it, right? Why would the nurse know he was even coming? Well, the problem is, if he's not, we have recall lists, and if they work like mine, he's off the recall list because we used the recall appointment to make this appointment, and then he no-showed. Do they stay on the list so they complete with you guys? Good, you have better software. Good. So this is actually a place where we fail patients pretty routinely, right? For whatever reason, they no-show. And it's very rare in our system for GPs to have the presence of mind to go through their schedule at the end of every single day consistently. I mean, I don't mean like hero behavior. I mean, every single day, at the end of the day, it's part of your routine to go through your schedule and identify patients that need to get called to come back in. Some people do it in my system, but it's because they're heroes. It's not actually a workflow that we actually have success with because GPs are finishing their days at 6:37 often, and they're not in any mood, and there's nobody around to talk to at that point either, right? Because they've got to, we're running late, they're trying to finish their notes. So I don't, but that's another place you could catch him. How many unfulfilled recalls do you think you guys have at your clinics right now? Yeah, 100? Right, because you have to use the recall. I know. This is nerd whining right now, you and I, but I'm on that page. And I think it's because we're all drinking from the fire hose, right? I mean, it's, again, nobody has any malintent. But also read carefully, I won't forget you, Jane. Read carefully here. He didn't no-show with me. Where did he no-show? At the specialty centers and with Shalini, right? So Shalini's behavior was not only to call him, but to alert the team.
When the person's on a care plan and they come in for their review 3 monthly, you pick that up then to see the specialist or the allied health.
He hasn't come in. He's disappeared. He hasn't come in anywhere now. No, he's on a recall list somewhere, but we have hundreds of people on recall lists. Why would we think about him in particular? No, I'm not trying to be a wise guy. I'm really not. I'm just pointing out where systems fail. So I have a system that works. We'll get to it. But this is not it. Recall was not it. We did recall, and we kept failing. So that's why I'm just trying to figure out if anyone has other systems. That's right. Jane's been waiting, and then excited person, and then other person who's already talked. Yeah, maybe he went back to Nepal.
His choice, he's changed GP. So
Yeah.
How hard to try?
Legitimately, Surya could have gone back to Nepal. I'm not kidding, because his visa could have run out, actually, right? What if my letter didn't work? It happens a lot. Excited person.
I was just, I'm going back to one of the first slides.
Yeah.
Where you actually put in a health proxy thing.
Yeah.
Yeah, which I don't believe is the system that we do here.
No, this is also not something that happens in every state in the United States. So it's a Massachusetts thing. A little weird. It is a great idea. It's a little stressful for 18-year-olds to think about this, but it's actually really helpful because we also then have a name in the chart when someone goes missing like this. I just call that number right away. You got it. I love it.
There's a brick wall.
You're made for team, kiddo. Yeah, no, you're made for team because it's like, yes, give me like 8 phone numbers and I'm happy. Yes.
The other thing too is for clinic to be accredited, there needs to be a recall reminder system in place.
Yep.
And I know when I still work on daily practice nurse as well as a PHN, so I know that's massive in our clinic.
Yeah.
And we wouldn't be accredited, we wouldn't have our accreditation. And we have tools that can help us apart from, so we've got, for example, PenCat and Polar, so there are tools there that
Yep.
can help us to make sure that we're capturing those.
So does anybody don't worry, I will not forget people. Does anybody have a system in place where there is one human being who is responsible for the recall list and keeps it under, say, 20 names? Good.
We have a system, or we still have a question practice, and we had all our diabetics on the suites, or even on MD, on the front page, you can pull them up and you can see who's
Good.
and I guess every day you would recall, you'd use your recall list, and you would have one person dedicated to recalling if they weren't already booked in for an appointment, or if they made,
Beautiful.
did not turn up for something, and we've even done to the point where we've actually, because we're in a rural area, have set the police out looking for somebody.
Yep.
There's a cardiac patient
Yep.
whose script came up that was well overdue, and we went out, because we have amyloid brain, he was trapped in, he was actually trapped in and he couldn't get out. So we actually were lucky that we sent the police out to go, hey, this guy's medication's showing up in red, and you really should be on it.
Awesome. So just for definitions, guys, what you just described is not a recall list. It's a registry. And this is actually really important because the registry is a list of patients that have a particular condition, usually a diagnosis. In this case, there's diabetes registries, there's hypertension registries, right? There's abnormal cancer screening registries like pap smears. And so the concept that I just want to impart, which is a supplement to a recall list system, is actually this registry-based system. And what we've used at my site with great success is that the diabetes registry becomes the panel of patients that the nurse manages. So Amberley has a panel of patients, right? They have my name on the chart because in the United States, your insurance card has the PCP listed, so we just use that because it's convenient and it's there. But the responsibility for wellness for everybody with diabetes in my panel and in Mike Thackeray's panel falls on Amberley, which is why they're so good. They take this very seriously at the clinic, right? And Kaitlyn backs up Amberley and Esme backs up Kaitlyn because it's all going to be their work anyway. These are their patients. I'll help them. But fundamentally, what am I doing here? I'm treating warts and I'm sending prescriptions in, right? This is not I'm not able to do the real work that needs to happen on behalf of Surya. It's actually not my job. It's not my role. I'm going to fail. And I think a lot of the burnout you see in GPs is that sense that, and certainly that was where I was for a while, is that I was failing every day and I didn't know what to do. So when you also have someone who is, has like superpowers in the area that you lack and they're right in front of you, this is where I turn back into a nerd. It makes me crazy that there's no system to just make that better, and that's why I'm so passionate about this work, is that I went from a state of constant failure to a state of constant joy. That's like alcohol. That's addictive, right? I've never tried drugs because I'm a good kid. I'm a doctor. Maybe it's like drugs. I don't know. I'll never find out because I'll lose my license. It's fine. But this is a really sophisticated system. If Amberly is reaching out for him when he missed a specialist visit, and I want everybody to be this sophisticated, right? Because this is really good patient care. And not a lot of effort, right, by me. We keep sending things to doctors and it's not working. And it's kind of like what happened to me when I went to Hong Kong and someone started talking to me in presumably Mandarin. I don't speak Mandarin or Cantonese, so I have no idea which one it was. And they said it twice, and then they started yelling at me. And I was like, this is frustrating. Like, speaking louder decibel is not going to help me understand this any better. I just don't speak your language. This is what it has felt like in the medical system to me for a long time, right? We just yell louder. We just say, you have to work harder, you have to do better without any real solution, and it's made me insane. I'm super happy, right, with this. Amberly, Kaitlyn, Esme, they're all still working at the same place because we're genuinely happy. And we're nerds, so we measure if we're happy. We're happy by some number, right? We have a number for happiness, we have it. So the interesting thing is, Surya came to the nurse visits, but would bop the doctors at this point, where he was like, okay, who's actually helping me here, right? So he prioritized the nurse visits, which is exactly what he should have done. He very quickly knew that that was where the money was. And it's not like he didn't want to see me or the neurologist, but what was I? I was like, his warts were fine at this point, right? The neurologist is like, I don't know, you'll probably get better. We'll find out, right? Like, Amberly's actually helping him. Shalini is actually helping him. So the moral of the story is, did it work? Kind of, right? I think you can see, Surya's a challenging guy. His wife now has prediabetes. I think he really likes sugar. I think he just really likes it. I think he's eating stuff and he just doesn't, because he'll sometimes disappear. And Shalini's still around, and I'm still around, and Amberly's still around. He still loves Amberly.
Is he a vegetarian? Is he a vegetarian?
No. So, we're still at it. I'm a GP. I see him, I see his kids, I see his wife. I figured when she got prediabetes, we were back to golden. Nope, they both disappeared last visit. So we've got them on the hit list, right? Carla's calling them constantly, and we're trying to outreach to them. But like as of today, he hasn't been seen in 2 months past his 3-month follow-up date. So we'll keep trying. He's not in Nepal. His visa thing's fine. Oh, it actually got better within 5 months, really quickly, which was great. Sort of. Because while he was really worked up about his eye, he was really doing well. But now he's like, it's fine. I'm like, oh, it's not fine. But this is just sort of what we've been talking about the whole time. But this is the team dynamic, right? It really is team behavior in this case. And that really is what's happening day to day with me, is that everybody, sort of all hands on deck. We sit together. We are co-located, which means there's a big room where everyone, all right, backing up. So in most of your clinical environments that I've seen in Australia, the practitioner sits in a room and goes and gets patients, right? And there's a one-room thing. In our system, I sit in a room with the team. So I sit with Esme and Carla and Amberly and another doctor and, right, the nurse practitioner and the PA. And we're all seeing patients using a panel, a sort of series of rooms, but patients stay in the room and we go to them. So if Amberly has to see someone and I have to see someone at the same time, the person stays put and we move around. It also gives us an opportunity to talk to each other constantly. So we were problem solving the entire time with this. So there's a structural component to your practices, which is really detrimental to nurses. And it's really tricky for you guys because you have this like, I rent a room thing, which we don't have. Like, we're employed physicians, so I work for Cambridge Health Alliance. I don't rent a room from the practice. I don't know. I empathize. Because I think that's one of the reasons why I see that doctors remain blind to the person who has the answer in front of them and are not doing that. Because doctors, right, the GPs here are lovely. I really like the GPs in Australia. They're really good people. They want the best. But if it's not easy to see, it's actually a lot to expect of them. And Madeline can talk about what she's doing with her practice to try and program around that. So I didn't spend a lot of time going over, right, what are we going to do exactly in a sort of programmatic way. But let's go back and let's actually look at this now using the lens of both change, right, transformation science, but also the building blocks, right, and the change concepts. Because what this case illustrates really well is what we call the patient-centered medical home, which is what Jane was so rapturous about, and what I've been building really since about 2000, which is a really long time now. And that system looks scary to me without this case in your head. So that's why I did this. I hope it works. So this is actually the roadmap in the United States. This is not the roadmap in Australia. I don't know what your roadmap is. I think we're studying it. Right. I think we're going to define it, right? That's what we're doing with the healthcare home. The most important thing is that you have to have leadership buy-in. If you don't have leadership, go home. I really do mean that, because I have seen more frustrated, well-meaning people get burnt out just at stage one. Number two is you have to measure things, and then everyone has to accept that measurements are valid. That's a big culture change. It sounds like you guys in this room are both at 1 and 2. This is check for you two. Empanelment is something that we do that you don't do because you have kind of put access, which is the second from the top, in the place that that I have empanelment, meaning you guys, anyone can call up and see any GP anytime, go to any practice anytime. We don't. We've actually put that on lockdown. You have to choose me as the GP, and then you have access to the practice. You can't make an appointment with me if Madeline's on your card. Sorry, I made you a nurse practitioner. You could be. So, because nurse practitioners and PAs are also GPs in our system, just so you guys understand the relationship. So when I talk about my role, I could be an NP, except that NPs would do this better, and we can talk about the details of that later. Why, right? Because they're nurse trained, and then they do stuff I get to do. So that's really impressive. Team comes after you have some kind of definition of what's the work. So you have to put registries where you have empanelment, the way we discussed with you, right? Then you can get in fights about how often you want to order tests, which is what organized evidence-based care is, right? So we have fights about how often do you get mammograms. Literally, right? The medical assistants were like, we need to get them yearly. I've saved people's lives with cancer because they actually order the mammograms independent of me, and they're the ones that actually have seen people come back with early stage cancer. And so when the evidence came out to move it to every 2 years after 50, they like literally held a meeting and said, we're not going to do this. And I was like, you go, dudes. I love this, right? Let's game on. Let's have a long, complex discussion about what are we going to do. And we had to come up with a compromise because they're so invested in their work that they weren't going to give. Ironically for us, you don't even get to the patient until you've done all of that, but that is actually my experience. I couldn't even listen to what people wanted until I had to check all of these things had to happen without me. Now I can hear people. Our access is terrible. You guys do access much better, but again, You're going to trade access for continuity. Continuity really matters in this case. Can you imagine what kind of care he would have gotten if we didn't even know he was ours and had that sense of ownership? This would have gone much worse. He might not have ever gotten his eye better because he didn't show up to his TB clinic appointment, and nobody would have known. And so that's where care coordination comes in, right? You have to have a sense of ownership as a practice, and you have to help people when they get bopped around our healthcare systems. And actually, I don't think you're any better at this than we are, sadly, because you could be. So please get really good so I can come back here in 5 years and just learn from you. This is what it looks like in Australia-ish. These are blocks, so you can kind of rearrange them, right? And this is the healthcare homes, which is kind of how I know you guys. And Tina, right, has been doing this. So this is kind of the Australian version of what we talked about, and what this, put these in blocks, right, more or less. You have some other modules in healthcare home that are specific to Australia that I can't remember the names of, but Madeline will be able to tell you all the stuff. Those are important, but the theory is kind of what I was focusing on. And again, I don't want this to seem overwhelming and difficult, because I think when you get 10 building blocks or 8 change concepts, I go on overwhelm. So again, keep it simple, guys. You need nurses, you need doctors, and you need them to get along. That's actually what you need to make team care happen on some level. It gets complicated quickly. You need registries, you need you need all these other things in some form, but fundamentally, if you don't have these 3 things, then you're not actually going to succeed at all. So that's why I separated that. There's the other fancy stuff is on there, right? You need structure, you need protocols, you need registries, and you need, right? That's what the structure is for finding patients when they disappear. And I would highly recommend you guys co-locate. I think you guys, doctors need to hear how spectacular your work is when you're on the phone with people, and that is actually one of the primary ways I've been able to convince GPs in my world to let go and let nurses step in and step up. And I managed to sort of finish on time.
Thank you, Kirsten. No, don't go away, because I broke a rule a little earlier, which is no one's meant to speak unless they tell us their superpower.
No, I did my superpower.
No, sorry, organisation superpower, because that's an amazing organisation.
I think so good. I followed the rules. I never follow rules.
I think though, if you were to think of the number one things you release a patient from your clinic, either a scan or a test, if you were to think about a superpower that you could have, that would mean they would stay there and you get that result instantly because your superpower allows you to actually diagnose something without having to send off a path or lab tests or anything like that, what would it be?
I don't want that power, actually. No, I'm actually quite serious. So I don't want that power, because I think it's actually very important for human beings to have a little time to process information. So I actually like the idea, I use this often in practice, where I'll kind of already know what's going on, and I want to give them, I'll stall. I actually want to give them, again, I learned this from nursing, I want to give them time to get emotionally there. So I'll order tests that I don't really care about. I just make sure that they're not tests that will come back abnormal, and then I have to chase that. So I order a lot of, I don't know if you guys use ESRs, erythrocyte sedimentation rate, like a measure of inflammation, right? Where I'm like, whatever, right? Yeah. No, CBCs are dangerous, because then you wind up, something's going to be abnormal, at least in immigrant populations. So I'm sorry, I'm not following the rules.
No, it's good answer.
But I actually feel like that's important, and that again is another one of those things that I've been able to do because of team care, both because I've been sitting and listening, had it role modeled for me, but also because I have time. I actually have time to be thoughtful. I didn't have time to think for years, and that was really frustrating, because that's supposed to be my job. So I'm going to politely decline that superpower, because I actually don't think it's good for my folk.
And let's keep thinking about that. What do you want to do? What don't you want to do? Because I think in change management, one of the big things will be actually biting off more than you can chew. And I think that's one of the big things, actually making sure your scope's defined, and we'll learn a bit more about that as well as the day goes on too.
But that's for Madeline to teach you. I'm done.
That's right. So another round of applause for Kirsten.